Hello, my name is Kalkidan Bishu. I'm an interventional cardiologist at Essential Health St. Mary's Heart and Vascular Center. Today I have a case of a transcatheter mitral valve repair at non-A2P2 location prepared by Dr. Atul Singhal and myself from our institution. I have no relevant relationships with commercial interests to disclose. Today we have a case of a 76-year-old male with a history of diabetes, liver adenocarcinoma, who's on chemotherapy, referred by his oncologist for NYHA class 3 dyspnea symptoms. A cardiogram suggested the presence of mitral regurgitation and aortic stenosis. He had a transesophageal cardiogram which showed mitral regurgitation that was severe in degree and aortic stenosis that was more moderate based on planimetry. The first moving image on the left is a 2D TE movie in the bicommissural view, showing the eccentric, more medial location of mitral valve regurgitation here. And this is associated with an eccentric anteriorly directed regurgitant stream. This is the last movie on the right, shows 2D TE long axis with flail P3. And also some calcific aortic stenosis. The first movie on the left is a 3D and fast view of his transesophageal cardiogram showing medial location of the flail P3 segment with a torn cord. And the transgastric short axis view is pretty nice and showing the origin of the medial origin of this regurgitant jet. The patient was evaluated by a multidisciplinary heart team, and considering that he was on chemotherapy with life expectancy greater than a year and marked heart failure symptoms, the recommendation was made to consider transcatheter H-stage repair of his mitral valve using the MitraClip system. We are planning on following up his aortic disease with continued surveillance. The first movie on the left shows patient's procedural TE. You can see the regurgitant jet as well as the MitraClip, the regurgitant jet that's originating from the medial commissure and moving eccentrically, and we have the MitraClip aligned in an 11 and 5 o'clock orientation across or perpendicular to the commissure. So this is the MitraClip, and the commissure is looking in that direction. In the movie on the right, we saw the grippers being lowered onto the anterior and the posterior leaflets. For leaflet rupture in the grasping view. And this is the final result on the movie on the left. You can see only trace residual mitral regurgitation with a stable clip that is medially located in this 2D bicommissural view with color Doppler. And this is a 3D and fast view on transesophageal cardiogram in the movie on the right. And you'll notice that the clip is practically located at the medial commissure. And there is only one opening orifice left in the mitral valve. So with regards to the invasive hemodynamics at baseline, mean left atrial pressure was about 20 millimeter mercury with V waves up to 70, with a V wave measuring up to 40 millimeter mercury. After the deployment of the single MitraClip, left atrial pressure mean came down to 8 with a V wave in the left atrial position of about 11 millimeters mercury. Final diastolic gradient is 3 millimeters mercury. This is on the TE transmitral mean diastolic gradient across the mitral valve. Follow-up, patient's symptoms are improved, and the patient is able to continue chemotherapy under oncology, and there's a plan for ongoing surveillance of his aortic valve disease. So that concludes the presentation. This is a question for review of what we've looked at today. Which of the following statements is true? Degenerative mitral regurgitation originating from non-A2P2 location treated with mitral clips associated with high grades of residual MR. B, 3DT and fast view with colored uppers essential in clip arm alignment perpendicular to coaptation line with commercial non-A2P2 locations. C, 20% of mitral clips are implanted at non-A2P2 location. D, implantation of mitral clip at non-A2P2 is more likely to lead to entanglement in the chordae. This is being defined as a greater than 1/22nd manipulation to free mitral clip. The answer key. Now, it's actually true that, while the majority of mitral clips that are implanted according to case series in published reports is in the A2P2 location, but up to 1 out of 5 cases, mitral clip is implanted in the non-A2P2 location. The likelihood of entanglement is more likely in non-A2P2 locations, primarily because of the presence of a lot of chordae in that location. Once we go below the mitral valve leaflet plane, the chances of getting entangled in chordae tendineae is higher just because of the concentration of chordae closer to the commissures. Because of the technical difficulty associated with mitral clip implantation in this location, high rates of residual mitral regurgitation have been reported in case series. And when trying to perform transcatheter mitral valve repair in the commissural areas and in the non-A2P2 locations, as shown in this case, the 3DT guidance with color Doppler, especially with the 3D in FLAS group, is fairly critical in appropriate alignment of the clip with respect to the location of the pathology as well as the regurgitation source. There's references are attached below. Thank you for watching this case.